Hello, everyone. Pediatric vascular access is one part of care, but it can shape so much more. How supported a child feels, how a family moves through a hard moment, and how care is experienced overall. That's why I'm so glad to be joined by Dr. Mary Beth Davis today. Miss Davis has spent more than 19 years in pediatric nursing. She has deep expertise in pediatric vascular access and central line care. Her work has taken her from the bedside to leadership and education and now into research. After earning her master's in nursing education, she completed her PhD at the University of Iowa College of Nursing and is now continuing that work as a postdoctoral scholar focused on pediatric vascular access. She's seen this work from so many angles, including, and this is particularly proud for me, firsthand experience with our Care+Wear PICC line covers, which she was one of the first advocates for and ensured that we got into the hospital. And her unique perspective gives her a really thoughtful lens on the details that shape care and the bigger questions that this field deserves. So, Mary Beth, thank you so much for being here. I'm really excited to chat with you today.
Yeah, thanks for having me. This is I was looking forward to this because you're just so easy to talk to. And likewise, you were one of my first industry partners that really helped me solve a problem I had. So I appreciate the collaboration over the years.
Yeah, no, and for those that don't know, Mary Beth is one of the first nurses I met when I started the company. And I still remember both of us were at this conference, the Association for Vascular Access, where both of us were like fish out of water, had no idea what we were doing. And it's been fun to see her become kind of one of the go-to leaders for the organization. And I get to ride her coattails to join the board. Um, but anyway, enough about me and you. Let's get dive into these questions. So you've spent so much of your career in pediatrics and vascular access. What first drew you to this work, and what made it something you wanted to keep building your career around?
I was, it probably goes without saying that I'm kind of a big nerd. And in high school, I was one of the few people that stood on that graduation stage and said that I wanted to be a pediatric nurse when I grew up. That's what I was going to do. And I applied to University of Iowa and got involved in Dance Marathon, which is a student fundraiser to raise money for
Incredible
breast
fundraiser.
cancer. Huge fundraiser. Met a lot of my friends there. Met my husband doing that work, he's also a nurse. And I just met these amazing families and these amazing kids. So I got to volunteer in the hospital through that, and then almost immediately got a nursing assistant job. And for 3 years, I was a nursing assistant while going to school full time. And on that same pediatric oncology unit. And so it was just sealed after that. I just knew that's really what I wanted to do. And so as a pediatric oncology nurse, that goes hand in hand with a lot of vascular access. And at the time, I didn't even know AVA existed. I didn't know what a vascular access specialist was. We didn't have an IV team or vascular access team at my hospital. And about 2 years into that pediatric oncology position, which after I graduated, I just stepped still where I was at, taking care of those kids, is that they asked if I could be the central line nurse.
Mm,
And what that job was at the time, it was 60%, which 3 days a week I was that, and then the rest of the week I staffed and took care of families, is that I taught nurses and families how to take care of central lines. One, when they're in the hospital from the nurse standpoint, and then when the families went home from the home standpoint. So
mm.
I'm teaching, parents how to do sterile technique. And this is going to sound so bizarre to any new clinician, but back then we didn't do sterile dressing changes.
Mm.
We did aseptic. We didn't have sterile gloves. We would access a
Yep.
port. We'd still scrub it and we'd have clean hands, but it wasn't a sterile procedure. So about 1 month into my new central line nurse job, we switched to going to sterile. So we had
Oh,
dressing change
wow.
kits for the first time,
Yeah.
had to do a whole overhaul for the whole hospital. And then a month after that, we started having to publicly report CLABSI. So before, we were aware of infections, but we didn't have, it wasn't a metric. And
Right.
so 2 months into my new job, I'm responsible for every central line associated bloodstream infection, and we were all just like still figuring out at the time. So that quickly made me realize that this is a big problem, a huge field. It impacts these kids and these families, and I just really wanted to learn everything I could about it. And in the process of doing so, there was just more questions. Like you'd figure
Yeah.
something out, and then more questions would come. But what people don't think about, I think when you think of a peds nurse, you think of like a perfect like 5-year-old size child.
Yeah.
But pediatric nurses, we get newborns up to like 26 years old.
Yeah.
So I at any given shift could have like a 5-day-old baby and have a 7-foot, 22-year-old patient.
Yeah.
So pediatric nurses have this huge range of exposure to all types of different sizes of patients. So I think from a vascular access standpoint, we have the whole book because we need it
Yeah.
in some cases to take care of every patient that we might need to take care of.
I know that's one of the unique things from our perspective when we started working with you. A lot of times when you work with a hospital, they'll be like, well, we only need this many sizes. But for you, you needed it literally sizes for a newborn up to someone who could weigh up to 400 pounds. And
Yeah.
so it's pretty incredible, and it must provide you with exhilarating days each and every day. And I think the fun part is no day is the same as yesterday, and I think that part is really unique.
Yeah.
Um, so obviously, in your time at the hospital, you've seen pediatric vascular access up close and personal. You have had to learn through a fire hose how to reduce CLABSI infections. You have obviously gotten to use our PICC line covers in practice. What have your experiences in the hospital taught you about the details that matter most in the room?
Yeah, when you're getting to know like each patient and their family is,
Yeah,
completely unique and different. And so like one formula doesn't apply to all. And so throughout the process is you just have to understand what's important to them, what their values are. But since I helped a lot in the hospital with what families needed, and also thinking ahead of when they needed to go home. And then thinking like 5 steps beyond that, like when are they coming back? Because for chronically
yeah,
ill children, they're going to be in and out of the hospital all the time. And we
right,
never wanted to set a tone for a bad experience that they wanted that coming back was going to be even harder. So I think there's still like this idea, like, even starting an IV, if you just hold them down, it's quick and easy and they'll get over it and it's just done. And, that's a good job. But what you realize is like over time, the more you do that, the less that child tolerates it. And like
right,
you, 1 to 2 years later, they're just not going to tolerate it at all anymore. And now you have a much bigger problem. So we always try to meet the family where they're at, see what needs they have. And then since we're a rural state, and
hmm
the Children's Hospital there is a regional hospital. So some of my families could be up to 5 hours away.
right,
And there isn't a close children's hospital for them to go to, or any hospital for them to go to. So, a big part of thinking ahead of when they need to go home is that if a problem happened at home, they're too far from us for,
right,
like just to whip back in for us to help them again.
yeah,
So, that's why a lot of the products we implemented and, things that we did was really to help set everyone up to be more successful when they got home and try to
love that.
anticipate what some of those problems might be.
Yeah. And I think for those that don't know, if you ever watch a University of Iowa football game in the fourth quarter, everyone turns and waves to the Children's Hospital, which is one of the coolest things I've ever seen and gotten to be a part of. And I think it's that focus on community and making the patient feel human rather
Mhm.
than, hey, you're just in and out. Kind of like you're saying, right? Like you don't want to think of it as a transaction. You're thinking of it as a true basically how you want your family members to be treated. And I think that's what really makes the care that you all provide so special and
Yep.
why people want to come back. And I know as a kid that spent a lot of time in the hospital myself, like having that relationship with your nurses is one of the things that helps make it less scary for when you do have to go back there. Um,
hmm
was there a moment, I guess, when you realized that the issue in front of you was bigger than one patient, one line, or one team, or that it pointed to a deeper pattern?
Yeah, I was thinking through this kind of specifically,
Hmm
and it goes back to like instead of transactions, actual experiences.
Yeah.
And, in my 20 years of being a pediatric nurse, like I've
hmm
seen these kids grow up. And it's just when you see those patterns over such a long amount of time, then you just realize that we just really have to be really thoughtful from the beginning of what this child and what their family needs, what those
Yeah.
past experiences were. And like sometimes the families that we get, they come in through like not a pediatric route, like a
Mm,
local ER,
right.
and they've built up a lot of trauma before they get to us.
Yeah.
And so then they come to us and we have this, we have ultrasound, now we have child life, we have, a dog specialist that help, like we've built up all these
Right.
resources. But as a pattern over time, like I don't want that kid to ever have a bad experience. So it's really been expanding what all of our bells and whistles
Yeah.
to knowledge and tools that anyone can use. So that the kids of Iowa don't have to experience something terrible before they can get to where we're at.
No, I love that. And I think it's kind of similar vein from our side. It's like how we really prioritize getting in front of all those experts and utilizing them to design and develop the products. Because at the end of the day, I don't know Jack, but I know people like you that know a lot. And so being able to leverage that expertise, I think, is really important while balancing comfort, durability, and workflow to help everyone at the bedside.
Mhm.
All right, so you've interestingly gotten to see pediatric vascular access from both the bedside and now through a research lens. What do those two worlds understand differently about the same problem?
Yeah, this was a really interesting question for me to like reflect back on.
Hmm.
But all of my research, including my choice to get a PhD, was informed by gaps of evidence in my clinical practice. So, when you like have helped write the standards and, have absorbed the standards and, you get to meet a lot of people through professional organizations, there were still gaps where I couldn't just pull up an article and know exactly what to do. That became really clear when, as a nurse clinician, I did a evidence-based practice internship. And
Hmm.
the problem I wanted solved, there wasn't enough evidence to solve it. So that really led to, okay, then we're gonna have to actually do some research to answer these problems so we can make better decisions moving forward. And I think as opposed to when I was at the bedside, when you're
Yeah.
so desperate to find the tips and tricks and like what are they doing? What are these other hospitals doing?
Hmm.
You just are feel like you're walking in blind to a lot of situations. And luckily, a lot of great research collaborations in pediatrics have answered some. Like for the mini magic decision, like some of these
Yep.
decision making tools have been really helpful. But now that I'm also a researcher, we've identified there's just a lot more ways to go. And there's subsets of really sick kids that we just still don't have really good answers for on what is
Yeah.
best from a vascular access standpoint. So for my research, I have two arms of research, and one is still focused on that hospitalized child that we are able at the very beginning of their treatment help them have the appropriate device
Hmm.
that's not going to lead to more harm. But then I'm also really focused in the home because I've gotten to know these families over the years. And when these kids go home and they're so far away, I can't say pop in and we'll help with a dressing change.
Right.
Um, I'm really trying to find better ways to support the parents because the parents end up
Love that.
doing all the medical care at home.
Yeah. No, and I think it's kind of goes back to that point of when you think about your care team, obviously your parents and other caretakers are going to be part of that care team, both in the short run and then in the long run as well. So I guess kind of diving into that even more, now that you're in academia and full-time research, what feels more urgent to you than they did, I guess, earlier in your career?
Yeah, I think earlier you just think if something like if a PICC line falls out or if an IV fails, like we just have to replace it and we need to
Yeah,
build up the skill of the inserter so that's easy to do.
right.
Now, like 20 years into that career, and some of my patients now are in their early 20s. What's most urgent to me is vessel preservation.
Hmm.
So if lines are getting infected and we're having to surgically remove them and replace them all the time, we're destroying vessels.
Yeah,
And it doesn't it can have like one line can occlude a vessel forever. And
right.
unless we do more procedures, we can't open that back up.
Yep.
And now that some of my patients are in their 20s, and they're doing okay with their therapies, I'm now worried that what happens when they get an adult onset new
Hmm.
disease and we've used up all their vessels as children and they can't get a hemodialysis catheter or a port for chemo or something. And so that's feeling a lot more urgent to me right
Yeah,
now is to place the right device when we need it. And then that device should be the right device to get through what their treatment is. So we're not constantly replacing 5 IVs before we do a pick for 2 days, for example.
right. No, love that. Um, if this field got the bigger conversation that it deserves, what do you think would start changing first?
I just wish that vascular access was recognized more as a subspecialty, like a
Mm,
medical subspecialty. Like when you do a consult for endocrine or consult for whatever, we take consults in the hospital
yeah,
as vascular access specialists, and we designed our consult system as not like you're requesting a specific line type, like you're requesting the specialist, and the specialist will come and assess, what they need, what's the history of vessels, what vessels are open, and help make that decision of what's best. And I think once that's more recognized as that's a recommendation, and we should follow it because they're the experts in this thing, then we'd see a lot less of, well, we're just going to keep trying for an IV 10 more times. Or even though the recommendation should be a tunneled line, we're just going to keep trying to put picks in until we can't. Like that's the gaps I think right now is like we're developing the expertise
yeah.
and it's not recognized as well outside of our own silo of vascular access specialists.
No, and I think it's the exact reason that I even started the company was because the non-vascular specialists were like, well, we don't want a PICC line to be infected, so make sure you wear a sock. And they were really focusing on function and not thinking about how does the patient feel, how can we make them more comfortable. And I think it's again going back to what you were talking about at the beginning, but it's realizing that these are our loved ones and our family members and letting them feel more human in the hospital is
Hmm.
so important. Awesome. Okay, now I like to do some quick fire questions.
Ooh, fun.
So just quick answers. First thing that comes into your mind. What is one song, show, or comfort that gets you through a busy week?
Oh, that's a good one. I'm a big music theater nerd.
Yeah.
And so when I'm feeling really stressed out, I'll like listen to like a rally song from Les Mis or
Hmm.
Hamilton. And then
Yep.
I really love the soundtrack from Last of the Mohicans
Oh, really?
with
Interesting.
Daniel Day-Lewis. And
Yeah,
sometimes if I'm having a bad day and I'm walking into work and I don't want to be there, I put those movie soundtracks on and then
I
I feel
love
like I'm
that.
on my own little super quest.
I used to when I ran the marathon, I trained to the Hamilton soundtrack, so I feel
Mhm.
you on great musicals. What is one question you think more healthcare leaders should be asking?
I think asking staff like what is really motivating you to be here
Mm,
and what what would keep you here for another year or
yeah,
something. And sometimes I think those answers can be really simple, like I want a more flexible ability to plan my vacation or something
right,
like that.
right.
But I just feel like people are opting in and out of things. And when you
Yeah.
have a solid, just because they don't like something, but that's not being communicated or there's not a venue to listen to it, I
Hmm.
think it is hard to be honest and say what you need to say and help get the answer you want.
I love that. What is one piece of advice you would give your younger self starting out in nursing?
Mm. I had the opportunity to say yes to a lot of really interesting things,
Yeah,
and I'm proud of myself for doing that when I was a younger nurse. I
yeah.
did an internship in Chicago. I did a summer mission trip in rural Africa. Um, but the advice I would give myself, and I think we did a good job of this, is just to make sure that everyone around you is on the same page and that you're able to support each other
Mm,
well enough and look out for each other
yeah.
so that everyone can feel like they succeed and do a good job.
Love that. What is one thing outside of work that people would be surprised you love?
I I don't know if anybody would be surprised by it, but I'm like a weird urban homesteader. Like
Mhm.
I have chickens and I like grow a garden and I
Yeah.
can things and maybe that's like stereotypical Iowa, but
Ha.
I do those things and I
Yeah.
find it so funny because by the time I put all the time and effort into like making a jar of salsa, that salsa's probably worth like $100, but
Right.
I still feel the need to do it every
Love
year.
that. I love that for you. And then lastly, what is your underrated productivity trick?
Oh, if I'm really struggling, I do the Pomodoro method.
What
So
is that?
so it's like the tomato timer, and you can
Oh,
get
okay.
like the timer to go up on your screen,
Yeah.
but I turn everything else off, like hide
Hmm.
my phone, everything else off, and for 15 minutes, you focus on the one thing you're supposed to do. Take a 5-minute break, do it again for 15 minutes, 5-minute break, 15 minutes, and then after that, take a longer break. And if it's not done, you assess if you keep doing it.
Love
But
that.
that's my left foot, right foot thing.
Yeah.
Like if you just have to do something you don't want to do it, you can do
Yeah.
it for 15 minutes.
My from my investment banking days, I still when I just have to buckle down and do something, I just put on like top 40 music and just jam out whatever I need to do, and I just don't pay attention to anything else.
Hmm.
Which everyone hates because I'm terrible at texting when I'm doing stuff, but no. Well, this has been amazing, Mary Beth. It's been so fun to get to talk to you today, and in general. Obviously, have gotten to become really good friends, and it's been fun to see you grow and become a leader and get to, as I wasn't even joking, ride your coattails, especially for those in pediatric vascular access. Mary Beth was a huge part of the reason that PD Neosig even exists for AVA, and just an incredible group of nurses like her that just want to help educate and share stories and learn from each other. So, really appreciate your taking the time today, and thank you very much for doing this.
Thank you.